Myeloid cells in hematological neoplasms. Leukemic myeloblasts vary in appearance and size. They can be large or small in size. Some may have a high nucleus to cytoplasm ratio, uncondensed chromatin, and usually one or more prominent nucleoli, while others may have a lower N by C ratio and a few red to purple granules or overrods. Nuclear and cytoplasmic irregularities may be present. For example, nuclear folding, cytoplasmic basophilia, and cytoplasmic blebbing or pseudopods. The recommendation is to count these as blasts and describe them in the film report with a suitable interpretive comment. Abnormal promyelocytes seen in hypergranular variant of acute promyelocytic leukemia have nuclei that vary in size and shape and are often kidney shaped or bilobed. The cytoplasm is packed with large coalescent pink to purple granules and may contain OR rods. These may be grouped in bundles or faggots within the cytoplasm. In the hypogranular or microgranular variant, the nuclear shape is usually bilobed, but the cytoplasm contains few or no granules. The recommendation is to count these abnormal promyelocytes as blast equivalents in the differential, but it is important that a suitable description of the abnormal promyelocytes and an interpretive comment is added to the film report, and a likely diagnosis of acute promyelocytic leukemia communicated directly to the clinician. Monoblasts are larger than myeloblasts, about 20 to 30 microns in size, with a round to oval nucleus, fine chromatin, and one or two prominent nucleoli. The cytoplasm is basophilic and usually lacks granules. The recommendation is to count these as blasts and describe them in the film report with a suitable interpretive comment. Promonocytes may be rarely seen in the peripheral blood in reactive conditions, as well as in some leukemias, and are large cells with a nucleus that is convoluted or indented with a delicate lace-like chromatin pattern and prominent nucleolus. The cytoplasm is bluish gray and may contain a small number of fine red to violet granules. The recommendation is to count promonocytes in the differential and comment on their presence with a suitable interpretive comment. Leukemic promonocytes should be summated with blast cells when making a diagnosis of AML. Abnormal monocytes are produced under conditions of bone marrow stress or stimulation. For example, infections, growth factor administration like of GM-CSF, and they show an increased NC ratio, a more delicate chromatin pattern, nucleoli, and increased numbers of vacuoles. Granulation and cytoplasmic basophilia may also be increased. Abnormal monocytes can be seen in a number of hematological neoplasms. In contrast to monoblasts and promonocytes, the abnormal monocytes are larger, have irregular nuclei, and increased cytoplasm. The recommendation is to count these as monocytes with a comment on their morphology and a suitable interpretive comment. Dysplastic changes refer to morphologically abnormal cells that are due to abnormal cell development and maturation. Examples of dysplasia include abnormally large or small clefts, nuclear hyposegmentation, nuclear hypersegmentation, hypogranulation, hypergranulation, and abnormal granulation. Abnormal granulation may be in the form of large fused granules or overrods. The recommendation is to comment on the presence of dysplasia with a suitable interpretive comment. Terminology for these lymphocytes has been varied and confused, with many different terms being used to describe the same thing, including variant, reactive, abnormal, activated, and atypical lymphocytes, Downey cells type 1 to 3, Turk cells, immunoblasts, and even combination of cells, for example, monocytoid lymphocytes. This highlights a need to simplify this terminology. So, it is recommended that reactive lymphocyte is used to describe lymphocytes with a benign etiology and abnormal lymphocyte with an accompanied description of the cells is used to describe lymphocytes with a suspected malignant or clonal etiology. Reactive lymphocytes or atypical lymphocytes suspect reactive according to European Leukemia Network classification. Abnormalities include increased cell size, immaturity of the nucleus including a visible nucleolus, and lack of chromatin condensation, irregular nuclear outline or lobulation, cytoplasmic basophilia, and vacuolation and irregular cell outline. The cytoplasm may be abundant with staining varying from pale blue to markedly basophilic, especially at points of contact with adjacent cells. The recommendation is to comment on the presence of reactive lymphocytes. They may be counted as separate population in differential if they are present in significant numbers. Now, abnormal lymphocytes or atypical lymphocytes suspect neoplastic according to European Leukemia Network classification. A comprehensive classification and description of lymphocytes in malignant lymphoid neoplasm is not possible to be covered in this video. For this, it is advised to refer to the WHO classification of tumors of hematopoietic and lymphoid tissues, 4th edition. It is recommended that abnormal lymphoid cells that can be identified as a particular neoplastic cell type, for example, hairy cells, lymphoma cells, and prolymphocytes, and plasma cells in plasma cell myeloma or other plasma cell dyscrasia be included in the differential as that cell class. Other abnormal lymphoid cells can be described in the film comment and counted as a separate population of abnormal lymphocytes in the differential if present in significant numbers. The use of this nomenclature underlines the limited diagnostic value of morphology in the lymphoproliferative neoplasms, where the final diagnosis is determined by immunophenotyping by flow cytometry. Hairy cells are seen in hairy cell leukemia, and they are larger than normal lymphocytes and have abundant pale blue to grey cytoplasm with fine hair-like projections. The nucleus varies in shape and may be round, oval, bean-shaped, or bilobed. It is recommended that hairy cells are counted as abnormal lymphocytes on first presentation with a detailed description of the cells included in the film comment. After immunophenotyping, the cells may be counted as hairy cells in the WBC differential. Cells seen in follicular lymphoma are often small with scanty, weakly basophilic cytoplasm and have nuclei with notches or deep, narrow clefts. Sometimes the cells are larger and more pleomorphic with small but distinct nucleoli and nuclear clefts or notches. Cells in mantle cell lymphoma are pleomorphic, varying in size and NC ratio. Chromatin condensation is less than in CLL lymphocytes, and some cells may appear blastic with cleft or irregular nuclei and a prominent nucleolus. Cells seen in Burkitt's lymphoma are large with dispersed nuclear chromatin, one or more prominent nucleoli, and moderately abundant, deeply basophilic and vacuolated cytoplasm. Cells seen in Sézary syndrome are present in variable numbers ranging from a few cells to a frankly leukemic picture with a marked leukocytosis. The cells may be large or small. The nucleus has deep narrow clefts with superimposed and folded lobes, giving it a very convoluted appearance. Cells seen in adult T-cell leukemia lymphoma have a broad spectrum of cytological features, but the characteristic ATLL cells have been described as flower cells with many nuclear convolutions and lobules. It is recommended that lymphoma cells are counted as abnormal lymphocytes on the first presentation with a detailed description of the cells included in the film comment. After immunophenotyping, the cells may be counted as lymphoma cells in the WBC differential. Plasma cells are larger than a normal small lymphocyte, having deeply basophilic cytoplasm, an eccentric round or oval nucleus, coarsely clumped chromatin, and a pale Golgi zone or perinuclear halo adjacent to the nucleus. It is recommended that plasma cells be counted as a separate population in the WBC differential. B prolymphocytes are twice the size of a lymphocyte and have a round nucleus, moderately condensed nuclear chromatin, a prominent central nucleolus, and a relatively small amount of faintly basophilic cytoplasm. T prolymphocytes are smaller and more pleomorphic than B lymphocytes. Nuclei are irregular or lobulated. The cytoplasm is scanty and moderately basophilic, and cytoplasmic blebs may be present. Nucleoli are usually not as large or prominent as B lineage prolymphocytes. It is recommended that prolymphocytes be counted as a separate population in the WBC differential. Smudge cells or smear cells result from shearing forces on the cells during the spreading of blood films. They are the disrupted nuclei of fragile cells. When the nature of the smear cell is apparent, it is recommended that they should be counted as the cell from which they are derived. Large number of smudge cells may be seen in CLL peripheral blood films. It is recommended that the automated differential be reported if available in this instance, but the presence of smudge cells may be commented on the film report. Leukemic lymphoblasts range from those with a high NC ratio, clumped chromatin, inconspicuous nucleoli, and scanty basophilic cytoplasm to those that are heterogeneous in appearance and have a nuclear chromatin pattern varying from finely dispersed to coarsely condensed. The nuclear outline may be irregular and nuclear clefting, indentation, and folding are common. Nucleoli vary in size and number but are often indistinct. A small number of lymphoblasts may have more abundant cytoplasm containing coarse azurophilic granules. Lymphoblasts cannot be reliably distinguished from myeloid blasts, lymphoma cells, and sometimes reactive lymphocytes. Additional information from cytochemical stains or immunophenotyping may be required to make an accurate diagnosis. The recommendation is to count and report these as blasts and describe them in the film report. Now, coming to platelets. Platelets are small, blue to grey granular fragments derived from megakaryocytic cytoplasm containing many small reddish to purple granules. Coming to qualitative abnormalities of platelet size. Size of the platelet is of diagnostic significance, particularly when considered in relation to platelet count. A normal platelet measures 1.5 to 3 microns in diameter. Large platelets measure 3 to 7 microns in diameter, roughly the diameter of a normal sized red cell. Whilst giant platelets are larger than normal sized red cells at 10 to 20 microns in diameter and are flagged by automated analyzers. In a normal person, usually less than 5% of the platelets appear large. Platelet size increases gradually during storage in EDTA anticoagulated venipuncture tubes. It is recommended that giant platelets be graded. A comment about the platelet count and the presence of small, large, and or giant platelets can be made with an additional interpretive film comment if appropriate. Hypogranular platelets exhibit little, if any, of the purple red granules found in the normal platelets. It is recommended that a comment about the presence of hypogranular platelets be made if seen in the peripheral blood film. Megakaryocytes and megakaryoblasts are rarely seen in normal peripheral blood. Small megakaryoblasts may be indistinguishable from lymphoblasts, whereas larger ones will have a nucleus with a diffuse chromatin pattern and a variable amount of basophilic cytoplasm, which may form blebs. Abnormal megakaryocytes, megakaryoblasts, and bare megakaryocyte nuclei may be seen in the peripheral blood in pathological conditions. Micromegakaryocytes are seen in some patients with hematological neoplasms. The micromegakaryocyte is defined as a megakaryocyte approximately the size of a promyelocyte or smaller with a non-lobated or a bilobe nucleus and a variable amount of weakly basophilic cytoplasm. The nucleus may appear bare, but a small rim of cytoplasm can be demonstrated by electron microscopy. The cytoplasm is weakly basophilic. Cytoplasmic vacuolation and variable numbers of granules may be present, and there may also be small cytoplasmic protrusions or blebs. Platelets may appear to be budding from the surface. It is recommended that a comment about the presence of megakaryocytes, megakaryocytes, and micromegakaryocytes be made if seen in the peripheral blood film.